the Trach Skills Lab. Yay! We have Jim Wallace here, who is our trach expert. He's expert in all things respiratory and trach, and a good nurse and a great teacher. So you will learn today, and hopefully you'll leave feeling like, yes, I can do this. It's not that bad. So, Jim, will you begin and help us learn great things?
Hi everyone, my name is Jim, and I'm a field clinician on Team 7. So it's like everybody here, I'm just a regular nurse, and I'm not an instructor. But today we're going to review tracheostomy care and what it is that we're trying to reinforce to the patient, and what it is we're looking for at the home. So first of all, before we go out to the patient's home, please keep in mind that the patient and the family already have had instructions on tracheostomy care, suctioning, that kind of stuff. So it's not like we have to start from the beginning. They already have that information, and so our objective is just to reinforce and see where they're at as far as their learning knowledge, and then just reinforce that from there. So we don't have to start the whole thing all over. Now, the anxieties that I find in the home is that because the support system's not there anymore, there's no nurses showing them, or the respiratory therapist is just now them alone, and that insecurity of am I doing the right thing, am I causing damage, that kind of stuff. So we're there just to cheer them on, encourage them, and make them comfortable as far as what they're doing with this tracheostomy care. So we're here today just kind of review, make sure that we're comfortable with what we're doing, and so we can pass this on to the patient. So the first thing we do when we get to the patient's home is make sure that all the equipment are there. The trach itself, and it is our protocol, if whatever trach the patient is on that we have one size smaller. If they have, let's say, a 6 shyly, then we should have a 4 in there. And the other thing we want to do is front load these patients for about 3-4 visits for that week to reinforce all this education. Equipment should include suction machine that is working, and again, they might not have it set up already, so you might have to set this up for them. And we do have one here, a portable suction machine, so that for you, those not familiar with putting one together, it's there for you to work on. Humidifier is also very important. As you know, oxygen is very drying. So especially if they're on high flow O2 trach mask, then they should have some type of humidifier. So again, a suction equipment, inner cannula, so on and so forth should be there. What if it is not there? What if the patients arrive and no equipment is present yet, especially the suction machine, for example, or the O2? What should we do then? Well, we need to notify somebody. Okay, it's not acceptable. Either notify your manager, the doctor, and if there's no supplies on the way, then the patient has to go back wherever they came from. Nursing home, hospital, ED, but they cannot remain there with absolutely nothing, okay, because that's a very dangerous situation, okay? So the biggest concern I have with the patient family usually is the suctioning, and so we're just going to reinforce all of that information, as I said earlier. So just ask them, what did they show you at the hospital? What have you learned from the hospital? And let's go through it together, me and you. So you're more like the cheerleader, you're going to be give them verbal cues what to do, and they're going to be doing the hands-on. So you don't do the hands-on for them, let them do it, because they've done this before. They've done a suctioning already. They've manipulated all this already. So you just give them the verbal cues. So everybody clear on that? Okay. So let's talk about the trach itself. There are several trachs out there. One is the metal type, the Jackson, and I really don't see that too often. These are the kind of long-term, forever kind of trach, and they're usually made out of brass type thing for infection control. You'll see mostly these trachs here that I have. This is Shiley, and this is a Portex. Now, let's start with the Shiley here. That's just your typical trach, and this one has a cup on it. So if I was to inflate that, that would be anchoring the trach to the where? The trachea, so that it doesn't move around. But it's not secure, okay? So we still need the trach tight to hold it down, because even if the patient was to give a good cough, that will pop out, okay? So that's the next thing we need to find out is where is your obturator, and this is the obturator. What the obturator does, it fits inside the trach and serves like a guide to when we are inserting the trach. Anatomically, it will help us in that placement. And then once the trach is in place, it should be, the collar here should be flushed against the skin. Then we remove the obturator and then put in our inner cannula, like so, okay? All right? So where should a trach be? Well, generally, if you look behind you, the carina is about 5 centimeters above where the right and the left bronchus split. So it should be right above that. Anatomically, it favors the right side, as everybody knows. So we want to make sure, and again, this has already been x-rayed, and so it should be in the right place. So we're still going to be listening both sides, breath sounds all the time. Listen, 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 okay? Even if it's been there forever. So when I see a patient with a trach, I want to make sure that it's in place. If they do have a cuff, that it is inflated or not inflated, whatever the circumstances be. And then I ask, where is your obturator? So everybody should know where the obturator is. And generally I tell them to put it in a plastic bag or a sandwich bag and tape it to the wall somewhere. So in case that, for God forbid, this trach was to pop out, and what's going to happen if this thing pops out, everybody's going to panic, including the patient, including you. So we need instead of looking for the new, where did we put that new bag? Well, pick up the old one, put the obturator in, put it back in, rinse it off, put it back in, okay? It is sterile, so, but then again, we gotta keep the airway open, okay? So, why does the patient have a cuff? This is mostly to prevent aspiration. Somebody who's, for example, bedridden, they're on tube feeding continuously, or somebody who's on positive ventilation, so that their cuff has to be pretty much inflated all the time. Otherwise, if they're walking, talking, and they just had they need a trach, maybe they have some kind of surgical procedure and there's going to be some swelling, or there's some paralysis to the vocal cord, they'll just have the regular trach without the cuff, okay? And so they'll be able to talk, drink, eat, whatever. And this is very, very easy to replace. It just comes in and out whenever we have to replace it. And we do replace the trach once a month. That's our protocol. And everybody can do it who's gone through this class. So everybody can do it, including LVNs. Okay? So the obturator is important, the inner cannula, cuffless, and then you notice here, this has little slits on the side of it. These are what called fenestrated trach. And why fenestrated? This allows the patient to talk, okay, whereas this one is not fenestrated, okay? Couple of things with the fenestrated trach. Of course, if you have a buildup of secretion, mucus, what have you, this will get plugged up, and there goes your fenestrated effect. So you have to keep this thing fairly well suctioned. But if they have really thick mucus, a lot of mucus, for example, then it might lose that effect. If, for example, though, if you don't have a passive neural valve is what I want to talk about. And it will work with the regular trach and the fenestrated trach, with the passive neural valve. Everybody knows what that is, right? So that it doesn't matter if you have it or not. So any questions about the trach itself? No, very good. So, what is it we're going to be teaching our patients on maintaining or keeping the ventilation or respiration without any problem? So, we want to make sure that the secretions are loose, that the patient is well humidified. So hydration is very important for these people. Mobility is very important for these people. We want whenever we're suctioning, we want to be able to get that phlegm out or the mucus rather easily. We want to avoid what we call deep suctioning, like as you can see on the diagram, we don't want to go way into the lungs and get the secretions out, because that's not necessary one, unless the patient has a very poor cough. We want the patient to cough it up. So we don't have to go in there very far, trigger the cough reflex, and then suction once that's going. If the secretion is very thick, then we can do a couple things. One is lavaging them with normal saline. We have those little bullets that you guys have seen. It's either the 5 ml or the 2.5. So when we do, just initially give them a half or 2.5 ml. And when you do lavage them, let it sit there for a few seconds before you go down to suction, okay? Don't suction right away. If it's still pretty thick, then give them the rest. You might have to do that a couple of times. It's really, really thick. And this is something you got to teach your patients as well, because with the trachea now, what they're breathing in, the ambient air, whatever they're breathing in. So if there's any kind of pollutants, dust, what have you, they're bringing that right in. So they can get infection rather easily, or get irritated, and they have this bronchospasm, for example. That's kind of severe, but it can trigger something like that. So people ask me, well, I don't want to walk around with this tube hanging on my neck. They want to participate, in, for example, maybe their kids' outdoor activities. Well, you put a scarf over it, or you can put a mask over it. If I'm going to be in contact with a lot of sick people, then either they put a mask on, or I'm going to put a mask on around my trach to kind of protect that. Okay. So another technique we can use to have good mucus mobility is, I'm sure you guys have done this before, the percussion, postural drainage. For example, if the patient is bedridden and they're really not moving a lot. Just to demonstrate, Nancy, can I borrow you? So if Nancy is laying in bed, and she was laying, the bed is here, the mattress, for example, she's laying on their left side. We just take our cup hand and just break that up, okay? And even Very good. I even put her head down a little bit to promote that, if they can tolerate it, you know. And then once I do that, I turn the patient, now she's laying on this side of the mattress, or she's laying on the right side, and then we'll do the other side, okay? And just break up the mucus and cuff, you know. So we're gonna be suctioning that, okay? So that's all what we consider pulmonary toilet. So pulmonary toilet is very, very important, that we do keep that whole area nice and clean, and so we're going to be doing quite a bit of it.
What I wanted to mention.
Mucus plug.
Exactly. Cool.
Mucus plug. If you do good pulmonary hygiene, you should not have a problem with this. Mucus plug is just basically, pardon the expression, just a big booger. Okay, that's clumped together, and it's blocking those little airways, and it's hard to get out, right? So suctioning is one thing, and our protocol is maybe do an ambu bag on them and see if that can break it up.
I wanted to present this piece to you. You do have it in your notes at the end. It's about the mucus plug. So first thing you're looking for is what would be the signs and symptoms of a mucus plug. So what do you think? Number one, patient is not
breathing.
Okay?
Difficulty breathing.
Yeah. Or difficulty breathing or not breathing.
Not breathing.
Secondly, you might notice the machine has an alarm going off. The third thing is if a person is non-vocal and maybe on a vent, there's an international sign for vent patients. If you're ever at somebody's house and you hear that sound, don't think they're cool and doing crazy rap music or whatever. What they're trying to do is say, I can't breathe, please check me, and do something. That's what it means. So sometimes we're like cleaning, but we're standing on the cord of the tubing. So we've actually, because we're standing on the oxygen tube, and they're like, get off the oxygen tube, please, move your foot. So that's that. And then the late sign of a mucus plug would be the color. That would be not right. So that's the signs and symptoms of mucus plug. B, you want to listen to and observe. Does the patient need suction? If they need suction, guess what? They'll sound like they need suction. You can hear them across the room. You know what that sound is. I won't imitate it. The other thing you might look to see if the patient's on a vent, is the connection loose? Is the hosing not quite doing what it should be? Is it kinked or disconnected from the patient? And then is maybe the mucus plug present? Steps to rectify the mucus plug problem. First thing you do, Jim said, is, do you think they have a mucus plug? Suction the patient. And then you can lavage the patient with how much? Half of the little bubbles. And then allow the patient 5 or 6 respirations after you do that, and then suction them again. Why would you let them breathe in between suction? Because they're plugged. Right, we all need to breathe, right? And then suction again and repeat till the suctions are clear. Third thing is you can try what Jim said, try the ambu bag on the patient, try to pop it down, try to get rid of it. Hyperventilates a patient, it can force the plug then to come up. So do that 3 times in suction, and if worse comes to worse, you maybe change the trach, because maybe it's stuck in the mechanics of that piece there. So that's the order for what to do in case of mucus plug. Right?
I want to go through the suctioning a couple more things. One is, again, like I said earlier, we want the patient to cough up as much as they can, and we're just going to get what's on top, right? We're not going to go way down there. And you can tell how often should I suction a patient? Suction them as long as they need it. So if you suction a patient, ask them to cough. If it's down, well, yeah, I got to go again. Maybe it's so thick, I need to lavage it a little more. Or they cough and go, well, that's pretty good, that's clear. That's the sound I want to hear. So again, we're not gonna suction forever, right? How long? No more than 15 seconds. So like I like to tell people, what if somebody came up to you and pinched your nose and put their hand on your mouth and say, breathe? Well, that's what you're doing to them, right? They can't breathe. You're sucking out the air, you're sucking out their oxygen, and it's not very comfortable. So you don't want to be there forever while you're on the phone, maybe talking to your whoever. That's not the time. You want to go in and out really, really quick, okay? And then give them time to breathe, you know? Once you suction somebody, let them breathe for a minute or so, you know? Let them catch their breath. Like, oh, hey, here we go again. You know, that's torture, so we don't want to do that, all right? So the question was, how often is it mandatory to be changing the inner cannula? The inner cannula should be changed once a day, all right? The Shiley here, you guys seen the inner cannula, the old type where you have to remove it by turning it counterclockwise, and then we use our tray kit here, clean it, and then put it back and click it on.
It has the blue dot on it, right?
Clockwise. So we really don't see that anymore. What we now see are the disposable inner cannulas. And with the trach care kit that comes to the patient's home, it really hasn't caught up with what we're actually doing out there. So this is a typical trach care kit. So let's open it up, and then you'll have your towels. Of course, this is, we're going to say aseptic as you can. We're not going to say sterile, okay? Because number one, we're now at the home setting, and they really don't provide all the necessary equipment that they need, not like in the hospital setting. So we're going to modify it a little bit, all right? So same thing, wash hands before and after, glove, drape, all that stuff. So I just want to point out to you what's inside there. You saw the drape. And we still have the trach tie here. I don't know, you guys look pretty young to me, so you probably don't even know what this is. But for those of us that's been around, like Rose, this is the thing where you have to cut it, and then you make a slit, and it's a pain. So they have these wonderful trach ties now that are very much more comfortable, and they're all Velcro, so you just put it around, and it just snaps onto the collar of the trach, and basically it fits like that, okay? So how tight should it be? Maybe one finger. You put one finger in there, that should be pretty tight, okay? So if they're breathing and this thing is going woof, 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 that's not very good, okay? You don't want that. So they have some gauze here and some gloves, okay? And gauze, of course, we're still going to use. And gloves, they can use the gloves. Now, this is a pipette cleaner. Again, this is from the old system. So what if you see a patient that has the non-disposable, then we would use the sterile technique, okay? So how that would happen is you have these compartments in this tray here, okay? So there's 3 here. So we're going to put one with that's half saline, half peroxide, half and half. One would be saline, okay? So what I would do is, if I have a trach, okay, and we have our cotton tip buds, there's usually 2 in here, which is not going to be enough. So probably you need a couple more of those. So at the trach side itself, I'm going to be visualizing if there's any redness, irritation, foul odor, some kind of complication that you might see. But usually that's fairly rare. I don't see that a lot. Okay, they do pretty well. So dip it with your half peroxide, half saline, clean up and down, okay. Toss that out, get another one, clean up and down, and then we're going to rinse it with the saline. Okay, same thing. You can even use some gauze to kind of make sure it's nice and dry, and then clean around the collar itself, okay? So, again, this is for the non-disposable inner cannula. So after I clean this, I now have my, where would I do it? Okay. So I have my inner cannula, which I remove. I toss it into my half peroxide, half saline with my sterile gloves. Now I'm going to clean this off, like so, right? This again, clean it, and then toss this guy out. Rinse it with the saline, then this guy is supposed to dry it, okay? Take some gauze, clean the outside, and then replace. Lock it in place, okay? That's the old way. Don't really see that anymore. With the new way, same thing with the cotton tip applicator. Just clean around the trach, peroxide and half saline. Rinse it with the saline, pat it dry. Take out the inner cannula, toss it, and put a new one in. And I'm done. So very, very simple. Okay? How about these guys? You can change this, like, I think every 3 days or even longer. And these, I think you can even wash these. So I don't know exactly what Medicare or the insurance will provide for the patients, but I know they'll allow them one of these a day. Okay, so much easier. And again, the patient's already been shown this. So it's not just reinforcing what they've already been told. And with changing the trach tie, if this is an existing one here already, and what I like to do is I put the new one behind the patient, and when I'm removing it, it's already there. Okay? I take the old one out, it's already there. And why? Especially if you're by yourself. If you can get somebody, the patient even, to kind of make sure they put a little finger on there. I don't trust the patient though, because I go, maybe a family member, okay? Family member, because they're going to cough. Anytime we move this trach or the inner cannula, that's going to trigger a cough.
Yeah.
And the last thing I want to do is, you're looking at the trach, and next thing you know, it's flying across the room. That's not a good thing to happen. So, always make sure, especially if you're changing the trach tie. When we're looking at the trach, this happens to be a number. Look at the size, okay? 4, 6, 8, 10. Most of those will take a 6. 4, you have to be a very small person. 10, you have to be a very large person with a big neck. Okay? So most people will take a 6 trach. So, and it's marked on here, okay? It'll say what it is. It'll say 8 Shiley, or the brand it is. Or if it's fenestrated, it'll have FEN on there, okay? So that's kind of important to know, so when you're talking to the doc, so he feels comfortable what you're talking, that you know what you're talking about. So tell him it is what the patient has. Doc's got a number 8 or number 6 Shiley cuffless, and the problem I'm having is blah blah blah, whatever it might be. Okay. So if this is a number 8, we need a number 8 inner cannula. Will the number 6 go in there? Of course it will. It's a smaller diameter, but it's the wrong size. Okay? Will the 10 go in there? No. Okay? So the size of the trach and the inner cannula has to match. I think we had an incident where the patient had a number 8 and then they had a number 6 inner cannula. Not a good thing. So bring that to someone's attention. Maybe the vendor messed up and they got the wrong thing going there. Okay? So make sure it's the same size. And when we suction, why not leave the inner cannula out? Suction like that, can we do it? No inner cannula suction? Sure, we can suction, but why? There's no need to do that. Make sure you put the inner cannula in to suction, okay? The balloon. So if we inflate the balloon, and I think it's on your handbook there, I think it calls for, if it's a size 4 trach, to inflate it with 11 ml. If it's a 6, 14, 8, 17, and 10, use 20. Those are just guidelines. Number one, it has to be air. Air only. Never put water, saline, or anything else in this cup, okay? So it just got to be air. And so of course that will inflate the balloon, right? You already know that. So when we're deflating it, if you're going to replace the trach now, which we do what? What's the protocol? Once a month or per doctor's order. We're changing it like once a month, and again, let's say LVNs can do this as well, okay? So when we do change the trach, we want to make sure that we're telling the patient that we're doing it, tell them to relax as much as they can. We want to lubricate this with the KY as much as possible. Check the balloon, make sure there's no leak, okay, before you put it in. And then this particular patient I was telling you about, we even put lidocaine gel around the stoma site and on the trachea cells, just to kind of help him with the process, because it's so painful for him. But if it's cuffless like this, then no problem. It just goes in and out. You know, just no problem at all. So it's the cuff that we have a problem with. So if we're in the process of doing that, so whoever's helping me, if there's somebody there, then tell them to inflate the balloon, deflate the balloon, and just remember how much you took out. If it's 10 ml, well, you want to put 10 ml back in there, okay?
And you just use a syringe?
We do it just a regular syringe with a lure lock in there, and then replace it. Make sure that the balloon is inflated again, and then listen. Always listen before you remove it. After you put it back in, always listen to breath sound. So now you can compare, and it's got to be bilateral. Okay, so right, left, not right, left. You don't listen to lung sound that way. So I think that's that, and
You should always have a smaller size inner or outer, the regular trach, available in the patient's home. Why?
Because if it closes, you won't be able to fit the other one in?
Correct.
so
Do they close? They close that quickly?
they close that quickly.
Jesus.
So as a matter of fact, if one day the doctor orders the trach out, they don't do anything. They don't put a suture it closed. They just let it close on its own, and it will happen rather fast. And that brings me to my story.
Yay.
I had a lady that I was seeing for a couple of years. She's on a ventilator. And when I first started seeing this patient, I always requested a nurse be with me, standby, just in case. And I think you guys have helped me. But this, this patient we've been seeing for a while, so I trained the caregiver and the daughter to assist me with this process, and we got really good at it. I mean, everybody know what their roles are, and I had the caregiver deflate the balloon, and we'd remove the trach, she would suction, and then it was teamwork. So every month, I'd get my stuff ready, preparing what I have to do, and I kind of remind everybody what they need to do. And the caregiver would give me the new trach. So I take the trach, get it set up, put my drape, blah, blah, blah. And this is just something we did every day, or every month rather. So, this particular time, this lady had a 8 Shiley cup, because she's on a ventilator. So, caregiver gives me the trach, new box, I open it, get it set up, everybody got their position ready, and we did it. Boom, boom, it was done. Less than 5 minutes, we were done. The daughter even says, wow, you're really getting good at this. We really worked together, very efficient. And I said, no, that was rather fast. So, the patient was fine, good pulse ox, breath sounds are good, no problem. I go home. Next day, I get a call from the daughter. Says, Jim, we're having a little problem. I said, what's the problem? Well, my caregiver is doing trach care, and she's trying to put the inner cannula in, and it won't fit. And I said, oh no. Say, what did you say? The inner cannula would not fit? I said, no, it won't fit. What's the problem? I said, I'll be right there. So our number 8, Shiley, she gave me a number 6. And dummy knee didn't look. Why? Because it's something we did every month. So I put in a 6 instead of an 8. Not a good thing. So it's been a good 24 hours since that trach change happened. So I know there's no way I can put another 8 in her. There's just no way. That thing is closed already. I called the doc, told him what the problem is, and I said, Doc, I know I can't put an 8 back in, so, and she's got, oh, I'm sorry, I didn't tell you what size. She has a 4. Went from an 8 to a 4. Got a 4 Shiley. I said, I know I can't put an 8 in there, but I'm going to see if I can put a 6. If I can't put a 6, she's going to ER. So the vendor that was providing the supplies for the patient, his name is Joe, happens to be a respiratory therapist. He's the owner. So I called him up and I said, Joe, I got a situation here. Can you help me? I need your help, just in case. You know, I need backup. And by the way, the respiratory therapist will not do this for you guys. They will not. I don't know why. That's what they had their schooling for and training. They will assist you, but they will not remove it or replace it. I think it's got to do with liability. I don't know what. So anyway, Joe showed up, and he brought us 6, and I said, let's try and put the 6 in and pray that it goes in. So we did, and long story short, the 6 went in, thank God. Good breath sound, good pulse oximeter reading, everything was cool, no problem on a ventilator. She wasn't pressurizing, no limits or anything like that, so everything was good. Called the doc, gave him a status report, and so just took an order to change the trach to a number 6 now instead of 8, which is probably more appropriate for her anyway. But so the moral of the story, I don't care how long you've been doing it, look at the side. So an obturator, what it does, it gives makes the trach, where is it?
It's over here.
It makes it, oh here, this will fit. It makes it, it won't fit. So it makes it stiff, so that,
So it doesn't go all sideways.
so as you're putting it in, it goes in, right? So you're putting it in, it makes the trachea stiff itself, and it follows the contour of the trachea. If you were to put it like that, you might put it in somewhere else, not in a proper spot. And we have had that happen too. A patient had paralyzed vocal cord. For some reason, it was halfway in, halfway out, so he was really having a lot of respiratory problem. And it took a day and a half to finally somebody figured out this ain't quite right. So they had to put him back in the. He's one of those guys, very big neck, and the normal trach, you have to have that XLT, extra long trach for him because he was such a big neck. And again, because of that, anatomically, it wasn't quite in the right place. So that can happen. So you always have to use an obturator to replace a trach every single time.
And if you look at the tip of the obturator, it looks to me like one of those ice boats, if you're going to the North Pole, which we've all done probably on vacation. But those ice boats, they have a certain
Icebreaker.
shape, icebreaker boats.
Yeah.
They have a certain shape to just go through the ice. And so that's kind of how that tip is designed, to sort of slick itself down in there, instead of getting a cutoff and just trying to kind of go in just with the end of the trach. So if you keep that icebreaker in mind, just like with my icebreaker, you'll be good.
So yeah. So this just if you can see it, it's like you skewer on your barbecue. It just kind of stiffens it and it helps along. Okay. So when we're suctioning somebody. Nancy, can you be my pretend patient? So here's my patient right there, and now I got my saline here. Now, all of you are used to, in the hospital, you have the suction kit. It has that little cup. You unfold it, put your saline in. You got your nice sterile glove, and then you have your suction. Right? In a patient's home, that's what you have. A suction catheter. Nothing else. No glove, no container, no saline. Okay? So that's just reality, guys. So what I generally do is I give them my little specimen container, that little plastic cup, put some saline in there, and I show them what to do. Okay? So the suction technique is still going to be the same. Okay? This is going to be my sterile, clean hand, so that's going to be there. It's going to be my dirty hand where I'm going to be manipulating the whatever it is I have to manipulate, right? So when I hook this up to my suction machine, what's the first thing I'm going to do? I'm going to test the suction machine and suction it, right? And then also, most of these suction catheters are self-lubricating. So once you run that through there, it will lubricate it, okay? So I'm going to tell the patient, if I need to lavage, what am I going to do? Use my left hand, my dirty hand. I give you a little saline here, I want you to cough, okay? So, squirt. Don't be looking at me. Yeah. Stay away from this area. Did I go in there? Go. So, give them a couple seconds to breathe. So now I'm going to suction. Give me a good cough. And then once you trigger the cough reflex, then that's when I apply my suction. Go out. Right? Put the trach mask back on. Let them breathe. Clean. Wait. How's that feel? Can you cough for me? Oh boy. You're still pretty gunky there. Okay, we can do it again, all right? Load the trach, lavage a little bit. And do it again here. Give me a cough. Cough, cough, cough. Suction. And then put the trach back in. Okay? And do this however long. That's it. You don't want to go one of these. This is what we call.
Oh my God.
Alright? So if you're doing that and you go, oh, it's kind of bloody. Alright? Now see my drawing there? So where are we going? To the right bronchus, right? And it's right against the tracheal wall and you're applying suction. And you hit that spot over and over and over and over again. Pretty soon it's going to get irritated, it's going to get a little bloody, okay? So, Jim, what do I do when there's a bloody secretion? Stop doing what you're doing, number one. Okay? You don't have to do this deep suctioning. Very, very few cases where we have to do deep suctioning. We don't want to really do that. Okay? Again, going back to this patient I was talking about, he has ALS, so it's got a thing here.
Yeah.
So he has a very poor cough, and it actually, and I've never seen one before till with this gentleman, he's got one of those cough inducer machine. They attach it to him, and it actually helps him cough, bring up the phlegm. So I've never seen that before. It's just one of those things. With him though, we do have to deep suction because he just has a very, very poor cough. But the rest of the times you really don't have to do that.
What I wanted to point out to you though on these handouts, the first page here is taken from a policy that was written for the managers to have when we're getting a trach patient coming to us. I left out all the stuff that the manager and the liaison have to do and just gave you the things that we need to make sure in place when we get into the home. And Jim did start this meeting with that information. So you gotta make sure that these things are available in the home. We're gonna check for O2 sat, we're gonna assess the trach, insert the suction catheter, and then all the pieces of equipment must be there on that first visit to make that a successful patient. So always make sure you kind of keep this little thing handy. I did email it to you so you will have it easy access. The other thing I wanted to bring out is ventilator dependent care guidelines. It's near the end, it's like 2 pages from the back. If you're like me, the thought of a ventilator is like, oh man. So, and all ventilators are different depending on the brand and how the settings are going. So this is just a quick guide review. Just read it before you go into the ventilator house. Again, like Jim said, they've had it a while. They'll be able to teach you how the ventilator works, but just make sure you look for these things. Number 7, emergency precautions and backup planning. Make sure they have a backup ventilator. Seriously, if their ventilator goes on the fritz, they're dying. So there has to be a backup ventilator. There also has to be a spare charged battery or alternative power source such as a generator. Because our power does go out in Montana. There has to be an ambu bag. Why?
Dislodge it, you can dislodge it.
You become a ventilator if something happens, right? Or the family does, so they know how to do that. There has to be, as we talked about, spare trach replacement, trach cleaning kits, and one size smaller, suction machine, humidifier, cleaning solutions, and an alternative plan for transporting the patient to the hospital. What we ask is that on the initial visit, you give the local fire department a call and say, hey, fire department, we're up the street from you on whatever Birch Street, and Mr. So-and-so is at this house, and he's on a vent and just wanted you to know. And they will put it on their master board, so if there's like a big disaster, they're gonna go to that guy's house and get him out first and get him to a care triage place, because he can't be in his home with a disaster. So just make sure you get a hold of the fire department and let them know. And then on number 9, these are just different settings you might find or need to know about. So I would take this paper in and read number 9 and then go find it all on my vent so that everything is set.
Want me to go over vent real quick?
Yeah.
You guys want to learn about vent real quick?
Yes.
Who worked with vent before? Ventilators. Okay, so I'm gonna use the board.
Yes.
So ventilator is positive pressure. So we have all this air being shoved down the patient's lungs, whereas we have negative pressure when we breathe, okay? So as nurses, we're not gonna be respiratory therapists. There are a few things we wanna know, okay? So one is tidal volume. Tidal volume is the amount of air being pushed into the patient's lung. And so again, that's going to be depending on the patient's size, right? The bigger the person, the higher the tidal volume. So usually it's around 400 to 500, okay? And so if we're putting in 500 tidal volume, what should be coming out or expired air? It should be about the same, right? Expired ventilation, okay? And then of course we have FiO2. So this is a fraction of the inspired oxygen, so whatever it is. Let's say 30%. So that's their FiO2, okay? And now we go with this assist control. What is assist control? Assist control is a patient is unable to breathe on their own. They're comatose, they have poor respiratory effort, and so the machine is going to give them the set number of breaths per minute. So if the patient's assist control is 16, well, the machine will give them 16 breaths per minute, whether they like it or not. Okay? So they're actually unable to trigger a respiration. Then we have the IMV. IMV is intermittent mandatory ventilation. And again, if this is somebody who's not able to trigger a respiration, this is somebody who is. So think of it like you're riding a bus. On assist control, I'm a passenger. I'm not doing anything with the bus. I'm just riding in the back. The driver is doing all the driving. So the machine is doing all the work. IMV is I am actually driving the bus sometimes. So this is somebody that we're weaning off the ventilator, or somebody that is able to actually trigger a respiration. So if somebody who's comatose, you're more likely to see them on assist control. If somebody's awake, alert, and doing all that stuff, then they're usually going to be on IMV, okay? And again, it will be 16, 18, whatever. So if the patient wants to breathe 20 times a minute, then the machine will breathe that for you, okay? But if they don't, then they'll just give that minimum amount, whatever it might be.
Which is your ALS patient? Your ALS patient, is he?
My ALS patient, unable to go on IMV, so he's on assist control, okay?
What does that stand for?
And then we have PEEP. PEEP means positive end expiratory pressure. So on our alveoli, it opens and closes to trap the air, right? And what PEEP does, it prevents that alveoli from closing altogether. So it's always partially open. So why do we want to do that? Instead of this patient, let's say their blood gas or what have you, their PO2 is low, and what I'm having to do is bump up the FiO2 to get my desired pH and PO2. Well, you know, you can't have somebody on high O2 for a long time. They become toxic. So I put PEEP. That enables me to now reduce my FiO2. That's the whole idea of this. Okay? So instead of somebody with an FiO2 of 50%, now I can put a little PEEP, and now I can bring it down to 30%, whatever. Okay? And then the last thing is pressure support. Pressure support is if I'm triggering a ventilation and I'm only like, and now it's like I'm gonna go, not quite there. I don't make a full breath. Pressure support will help me. So if somebody like you're going up the ladder and you're not quite making it to the last step, somebody will push you from the back end and get you there. That's what pressure support does. Okay? So for nurses, that's all we need to know. There's other things like minute volume and all that stuff. Who cares? Let the respiratory therapist handle all that. But for us, this is what we need to know. Okay? What's my tidal volume? What's my FiO2? Is it assist control or IMV? That tells me a lot. What the patient is doing, you know, what kind of patient is alert, comatose, what have you. And then the higher the peak to maintain the PO2, then the more problem they have with their pulmonary status. You know, maybe somebody who's end-stage COPD, for example, that kind of stuff. So that's it. I just want to go over that.
Thank you.
And again, Ventilator is a positive pressure. So complication number one, for somebody I'm going to look for who's on a ventilator, what is the number one thing I'm going to look for? It's pneumothorax, spontaneous pneumothorax. And so that's why breath sounds are very, very important. Got to listen both sides all the time because they can develop this spontaneous pneumothorax. And the other thing is subcutaneous
Emphysema.
emphysema. Okay, and it's like those wrappers that they have, and you feel that the skin is popping. That's subcutaneous emphysema. There's nothing you can do about that.